We're trying to get the band back together up front here, which means the rest of the attendings, if panel could be up here. I'm Lawrence Garcia with Nick Shamus. Nick, gosh, I've known you for 25 years. Nick is in Iowa. I'm now in New York from Boston. We have a panel, if I could have them come up. They're probably going to be late. Dr. Abu Fadel, Dr. Bunty, Bailey Estes is on here as well. Dr. Feroz, Dr. Rao, and Dr. Rosal. All right, so we are good to go. Do you have all the talks, or do I need to? We're all set? Okay, perfect. All right, so let's start up. We're going to try to stay on time. 10:30 to 10:40 is going to be Dr. Al-Halbadan. Is that close? I apologize if I destroyed that last name. Superior vena cava angiosarcoma, biopsied using the Inari flow retriever. That's a great, interesting title.
Hello everyone, my name is Nawaf Al-Habdan. I'm a third-year internal medicine resident at University Hospitals in Cleveland. I have no disclosures. Our case today is a 29-year-old female with past medical history of bilateral pulmonary emboli and an SVC thrombus that was diagnosed in March of 2023. Testing at that time showed that she was positive for a heterozygous factor V latent mutation. In October of 2023, she presented again with acute on chronic pulmonary emboli and evidence of progression of the SVC thrombus. This was believed to be failure of her DOAC therapy. She underwent ECOS thrombolysis with minimal clot burden resolution and no improvement in oxygen requirements. At that time, and with discussion with our cardiac surgery colleagues, she was planned for pulmonary thromboangioplasty for CTEPH. However, the patient elected to leave against medical advice and was discharged on low molecular weight heparin with plan for follow-up for outpatient arrangement for surgical pulmonary thromboangioplasty. However, before that was done, the patient presented again in February of 2024 with shortness of breath and chest discomfort. These are her vitals and blood work tests on that presentation. She was tachycardic. She was on 5 liters oxygen compared to her baseline for the past year, which was 2 liters. She had leukocytosis and AKI and evidence of acute liver injury in addition to elevated lactate. Her CT scan when she came in, a CT-PE protocol, showed that the bilateral pulmonary emboli were about the same. The SVC filling defect, believed to be the SVC thrombus, was progressing, getting bigger, and she also had evidence of multifocal infectious infiltrates. Here we have another image showing us the progression of the SVC filling defect. Panel A, you see it in October of 2023, and panel B, you see it in February of 2024. This is her echocardiogram on presentation showing a severely enlarged right ventricle with very highly elevated RVSP. So at that time, patient was treated with IV antibiotics and diuresis. That resulted in the resolution of shock and improvement of oxygen requirements back to her baseline, which is about 2 liters. Given the intramural nature of the SVC filling defect, believed to be a thrombus, interventional cardiology was consulted by the medical ICU team for endovascular sampling of that filling defect to rule out malignancy. So the patient underwent SVC mass suction using the Inari flow retriever, traditionally used for mechanical thrombectomy. A 24 French Inari retriever catheter was advanced from the right groin femoral access to the SVC. Multiple aspirations were performed, removing sample for pathology. You can see on the image that the samples that were obtained were more consistent with a mass rather than a thrombus. So these samples were sent for pathology, and the results showed evidence of angiosarcoma of the SVC. A PET scan also showed evidence of mets in the supra and infraclavicular lymph nodes and also the pancreatic head. The patient was transferred to the oncology service and was started on chemotherapy. Our key learning points here are Be aware of anchoring bias. This patient had been labeled as having an SVC thrombus for over 1 year, despite the progression of the mass. It's easy to anchor when you have another piece of information. In that case, it was the fact that she was positive for a heterozygous mutation of factor V Leiden. The other point here is mechanical thrombectomy devices are a versatile tool that can be used to remove thrombi, or even as in our case, biopsy intraluminal masses. When we went in, we didn't know that it was a mass, but we were able to get samples that eventually led to the diagnosis of this patient. I would like to thank my attendings and supervisors. Thank you so much.
Thanks. That's an interesting case. Paper's open for any discussions. Anybody have any questions?
Where do you think this? Thank you. Where do you think this sarcoma is coming from? Is that the right atrial sarcoma into the SVC? Because that's typically the presenting kind of feature.
So I actually went back and looked into her CT scans. Even she had presented even earlier than March of 2023. And I was looking, and I think it started actually from the SVC, which is very rare. I looked at the literature. There's only 2 cases reported prior in the literature about SVC originating angiosarcoma. As you said, it most commonly arises from the right atrium and goes to the SVC. But in her case, I do believe that it originated from the SVC.
This would be an extremely rare presentation.
Exactly.
I mean, there's probably 2-3 cases in the whole world like
exactly.
this.
That's exactly the number I found. It's like 2 or 3 cases.
Should probably publish it.
Is
there a risk of taking some biopsy? I don't know how this thing grows except local invasion, but can you embolize it and create a new focus in like the pulmonary circulation?
I mean, theoretically, I believe you can. I don't know if there was like any sort of protection being done during that time, but I think there is a theoretical risk of that happening too.
Probably the mass was too high up all the way to the, you could always see it in the CT, the last CT you did, almost going up into the right atrium, probably all the way up. So if they biopsied from way down there, even if something embolized, there's nowhere for it to go. But in general, I mean, all these, angiovac, this device, all this we use for PEs and stuff, there's always a risk of embolization. I mean, I've never seen it being used for biopsy just for that. Of course, it's not
right.
not intended for that. But if there are small masses and stuff, they usually get sucked out. The problem is, unlike thrombus, they don't just get sucked out. They get pretty much like you are taking a chunk, and if it's against a wall or something, you can rupture the SVC or something. But in this case, it was full of mass. I think that was not an issue.
Yes.
But you always are worried about that.
Yeah, we did a case with Vortex back in the day when it was still that 26 hooded thing for a guy who had renal cell carcinoma and had a IVC repair, and then he ended up rethrombosing it, but it was rethrombosed due to the cancer cell growing, and we ended up having that same biopsy thing. What's the follow-up for this young lady? Because, I mean, CTEPH notwithstanding, if there's something else going on,
she was started on chemotherapy on the cancer floor, but eventually she did not tolerate chemotherapy and elected to leave the hospital with hospice. Yes.
Two questions here. So this was an angiosarcoma, but are there other tumors that could potentially present intravascularly?
Yeah.
What did you say?
Renal cells.
Oh, renal cell.
That would be a big one that you see very frequently in the superior vena cava, quite a bit actually.
Yeah,
sorry, in the inferior vena cava. I apologize.
Yeah. Inferior, and then it kind of rolls up into the RA. Yeah.
The follow-up question is, oftentimes with the Nori flow retriever, if there's chronic clot, it's very difficult to pull it out. Acute clot just comes out very easily with aspiration. So in this procedure, did you all have to aspirate over and over again to get the specimen that you did, or how easy was it to extract specimen in the aspiration catheter?
I don't believe we had to do it multiple times. I believe we were able to suction those samples. I mean, we had to do multiple rounds, but I don't believe that was an issue at that time.
Can I ask one question?
Go ahead.
So I know she came in and you found sarcoma and
yes.
She's on hospice care, but is this the time now to consider like balloon angioplasty of the PA just so she breathes well until she dies?
I think that's a great question. I mean, she did not tolerate any of the chemotherapy. I think that might have been an option to improve her quality of life for the time that she had left. However, she elected to leave with hospice. But I think this is a great point. It might have improved the quality of the life for the remaining time that she had.
You know, the right atrium was clearly involved, you know,
Yes.
and you can see that. So really, you know, you have to take care of that right atrial large mass, otherwise you're not going to change a whole lot.
I think the most important part that you made in your presentation is the anchoring bias, right? If you've got a young woman that's coming in with an SVC thrombus without a history of a catheter or other manipulation or surgery, you've got to take a step back and ask, right? That's an odd location for
Yes.
someone to, as a primary presentation, as for a thrombus. So I think that's a point that we all need to remember. Sometimes we think we see cool things and we're like, oh, it's definitely that, but to take that step back and think about the whole clinical scenario.
All right.
Thank you.
Thank you so much.
Thank you. So, yeah, we're going to go ahead and move for the second case. Thank you. So the second case is a case of inadvertent femoral artery cannulation presenting with large groin hematoma and hemorrhagic shock by Felicia Orn.
As they're coming up to the podium for the panel, we're going to be grading everybody on presentation, illustration, you know, talking points, and how they deliver their talk. So you get 10 minutes. Take your time.
Thanks so much. All right, well, everyone, and thank you so much for having me today. Thank you, panelists, for being here. My name is Felicia Orn, and I'm a third-year internal medicine resident at Broward Health Medical Center, Fort Lauderdale, Florida. I'll be presenting a case of an inadvertent femoral artery cannulation. I have no disclosures. So we have a 76-year-old female who presented with dizziness, fatigue, and abdominal pain. She was found to have a heart rate resting as low as 30 beats per minute. Her past medical history includes hypertension, chronic atrial fibrillation with multiple prior hospitalizations due to RVR, type 2 diabetes, a previous CVA, and peripheral arterial disease, just to name some of the pertinents. So due to the symptomatic bradycardia, the patient was evaluated by the EP service, and the decision was made to proceed with AV nodal ablation and pacemaker implantation. Firstly, she underwent a successful pacemaker implantation, and proceeding with AV nodal ablation, the operator gained right femoral venous access without ultrasound guidance. The case continued uneventful up until shortly after catheter and sheath removal and placement of a Minx closure device. The patient developed a rapidly expanding right groin hematoma while she was being prepped for transfer out of the EP room. Despite aggressive manual compression for 1 hour, the patient showed evidence of hemorrhagic shock, which included profound hypotension requiring pressor support, diaphoresis, tachycardia, tachypnea, and her rapidly dropping hemoglobin of 10.7 to now 7. So due to the continued hemodynamic instability and rapidly deteriorating clinical condition, an angiogram and emergent endovascular repair was pursued. So this is the emergent angiogram. We access this through left femoral arterial access and advance to the right femoral system. And we see that the uncontrolled bleeding site is at the right SFA. Now, using a 7 French destination sheath, we advanced a glide wire to the right SFA. Here's the next view. I'm going to give a moment for everyone to take a look and see if we can appreciate any other findings in this view. And so what we see is the right femoral vein is now visible. So this suggests that we now have an AV fistula in addition to the uncontrolled bleeding site. So the area of perforation was sealed with a LifeStream 7x37 covered balloon expandable stent and post-dilated with an 8x20 balloon. The patient's hemodynamic stability was immediately achieved upon stent deployment. And this is the post-interventional angiogram showing both resolution of the AV fistula and the bleeding site. So critical situations call for urgent intervention, and the choice of therapy was chosen due to the patient's dire clinical condition and our institution's logistical factors. We used a covered balloon expandable stent, and her hemorrhage was immediately controlled with subsequent restoration and hemodynamic stability. The covered self-expanding stent was preferred, but an appropriate size was not readily available, so the emergent decision was made to use the covered balloon expandable in efforts to save our patient's life. And so this is just for consideration in when we intend to gain femoral arterial access. We aim for the site 2 centimeters below the inguinal ligament to reach the common femoral, and a puncture above the inguinal ligament could result in a retroperitoneal hemorrhage that may go unnoticed, and a puncture below the arterial bifurcation could result in pseudoaneurysms, AV fistulas, and the limitation of large bore TG catheters. And so to further emphasize the prospect of complications, when we gain access without using visualization, there are many anatomical variations that exist, such as venous malformations, duplication of either the SFA or femoral vein, and its branches seen in correlation with post-thrombotic syndrome and varicose veins, as well as alteration secondary to previous surgery. And so this is to emphasize the close proximity of the SFA, the deep profunda artery, and the common femoral vein, and consider that the slightest angle deviation of access could accidentally puncture any of these nearby vessels, and thus the inadvertent puncture of the femoral artery could happen easily without direct visualization using ultrasound guidance. So if I haven't convinced you yet, in January of this year, a meta-analysis was published in Neurointervention performed by Giuseppe Gargiulo and Danielle Giacopo that reviewed several randomized trials, all suggesting that ultrasound guidance was associated with lower major vascular complications as well as a lower number of puncture attempts. And this is the statistical significance published with their paper. So key learnings for the operator and the team is that prompt recognition and timely management of vascular access-related complications have a direct impact on patient morbidity and mortality, and the application of appropriate endovascular techniques could provide a life-saving measure in unstable patients. Many vascular anatomical variations exist and is patient-dependent, and most importantly, the use of ultrasound guidance may reduce your risk of complications, and it should be routinely used in your lab as a preferred method for vascular access. These are my references, and thank you so much for joining me today.
This is a very important topic and very close to my heart. You know, I've done all my research publication, even have a book published on vascular access, and I think for interventional cardiologists, we keep hammering this on every meeting and everything we say, and I'm hoping all the new interventionalists, upcoming ones, will really start using ultrasound more. The older ones has been very difficult to get them to change, at least in our practice sometimes. But the interesting thing is that this was EP. So I don't know what we need to do to teach the EP people to use it for femoral access. Obviously, this was a very low stick and bad stick. But that may be something to consider, trying to talk some of our EP colleagues to use that more. I really don't know what EP, how many of them use ultrasound access. And I'm glad you mentioned balloon expandable versus self-expanding stent. I think this is a very important point. One could definitely put a balloon and tamponade the flow to get a self-expanding covered stent. And usually, you know, we size it 2-3 sizes bigger than the artery is still okay most of the time. But if it was absolutely not available, then you need to save the patient's life. So, yeah, thank you.
Yes, yeah, I appreciate those comments. With us, we had very small stents for the self-expanding, so we didn't want to leave a floating stent in place. So, and I agree, and you know, ultrasound guidance is very important. I think there's a learning curve that comes with ultrasound guidance use, especially when it's been habituated without the need of it. So,
you know, some of my worst complications when I was at the BI was from EP. And it was challenging, and this was before ultrasound really caught on. And then my old institution at St. Elizabeth's, another major complication from our EP colleagues, and so now they always use ultrasound guidance. But here's the question: so what you said something very important, and that is experience is important, and it's a learning curve. What's the learning curve? What do you need to look for on ultrasound if you want to recommend it?
well, so when we're using ultrasound, I mean, there's different probes, we have different machines, we have different usage, and it's also the availability per the facility. And I think with each operator, if we're not used to using it and we have to change different facilities to use a different one, it becomes a little difficult, and it is, you know, harder to pick up a habit that we haven't been using for such a long time. So.
Yeah, I was thinking more pragmatically. So the real key is not only to use it, but then know what you're looking at, right? I mean, people can find a hole, and that's the artery, and they stick it. The challenge is that that's not the point. The point is you need to define common femoral to the division. And what you showed there on the upper right on that anatomical picture is from my old colleague, a guy named John Skillman. They wrote this out of the cath lab at the BI, 20 some odd years ago, maybe 25, 30. And that was the femoral head is where you compress. It's like pushing against sand. You can pound sand all you want, you'll never do anything. If you get onto the femoral head, whether it's the SFA or the common femoral, you can occlude that. When you get below it, you can't compress. There's nothing to compress against.
Right.
And retroperitoneally, unless you have a crush injury to your pelvis, you'll never be able to control that.
Right.
So that's where that picture becomes so critical. But ultrasound, you can use it, but you have to know what you're looking at, and that's the learning curve. The learning curve is defining common femoral to the division.
Yeah, just to answer your question, so in our, Dr. Sito and I did the FAUST study, and in that study, around 15 ultrasounds were needed to get competence. We recently did a, Universal study came out from Canada, and we combined all patients of Universal and of FAUST, so 2,000 patients, and we did all the data. And after 20 ultrasound usage, you are good. The pitfall is the ultrasound does not tell you how low you are. You really have to still use fluoroscopy to find the lower head of the femur, lower edge of the head of the femur, and then ultrasound from there upwards to be above the bifurcation. And this is something that's very important, because if you use ultrasound alone and the bifurcation is low, you can still hit the common femoral artery, but be below the head of the femur, and you won't see that with ultrasound.
So just a quick question. Do you have any insight why there was a wait of almost an hour before this had been taken care of?
Yes, so
I mean, normally you see something expanding to that speed. You want to really jump on it right away.
And the hemoglobin went from 10 to 7, which usually takes 12 to 14 hours.
Yeah, exactly. So, this is very important, is when you start seeing an expanding hematoma, you're not controlling it just with literally not more than 5-10 minutes. You better act on that stuff.
yes, correct. And unfortunately, there was a delay in recognizing this. So the operator had closed and they had left the room. The tech who was cleaning up the patient had seen that there's a rapidly expanding hematoma. As she was placing compression, it was already too big that the force and it was just not going to. Yes, yeah.
This is a little bit of a trick question, but why did you guys not get a CT scan?
I'm sorry, why would we? Could you repeat the question?
A little bit of a trick question, but why did you not go get a CT scan first?
To be honest with you, given her extreme clinical condition that she's exsanguinating, I don't think that we would have obtained a CT scan quick enough.
That's the exact right answer.
Yeah.
No, it's a point to make. If you have an access point problem, going somewhere that's only going to delay the problem and not get control of the situation is the wrong answer. So that's exactly right.
Go to the lab. All right, thank you.
Thank you.
Next up, if I can have Dr. Anand, successful navigation of total occlusion using ipsilateral transpedal approach.
Morning, everyone. My name is Albert Alexis Anand. I'm currently a second-year medical resident with Texas Health Resources. I'm grateful for the opportunity to present this case today. I observed with my attending physician, Dr. Peter. I have no disclosures. So I present a 73-year-old male that presented with exercise-limiting claudication to the clinic for pertinent cardiovascular history. He has a known history of peripheral artery disease. ABI back in 2019 was normal in the right leg and was 0.71 in the left leg. We also did obtain an arterial Doppler, which showed pretty much monophasic flow. He has hypertension, congestive heart failure with mild MR. Other history to consider is he's a chronic smoker. He has a TIA and GI bleed and anemia. So for our imaging and diagnostic studies, this was the diagnostic ABI we had. So you could see on the right side, he has this diminished Doppler waveforms, and ABI on the right was 0.71. We also did obtain a toe brachial index, which shows the diminished Doppler waveforms. And on the left, the PVR waveforms were also not that good. So this was a diagnostic arterial Doppler we had. You could see the pretty much poor flow going through the proximal left femoral artery. And in the mid, we still have some flow, but it was still poor, pretty much monophasic. So we tried to intervene, we went with the angiogram through the right, and we found out that he has like 100% occlusion of his SFA, which we actually tried to go antegrade, but we were unsuccessful. So I guess the clinical challenges, given the limited medical treatment options due to a prior GI bleed, considering the fact that an antegrade CFA procedure has already been unsuccessful, what should be the next step? So I don't have the images to show us, but pretty much this is what my attending did. So we obtained a retrograde access via the transpedal approach through the left anterior tibial artery. We actually placed a 6 French cylinder sheet, and we used the Viance microcatheter. We're able to advance it all the way to the SFA ostium, and we confirmed the position intraluminally, and we exchanged the run-through wire to a guide wire, and was able to pass the CTO to the common femoral artery. So the next step was to do a side switch, because from my understanding, we never work from the retrograde axis. We always go antegrade. So we navigated our guide wire from the left to the right destination sheet, and we worked our way antegrade just like we do in the traditional fashion. So we advanced the twin pass microcatheter, went antegrade to the left SFA. We also used the 5 mm shockwave lithotripsy from the ostium all the way distally, and we placed the Boston Scientific 6x150 mm stent, alluvia stent. And for the distal residual stenosis, we actually used a drug-eluting balloon, which was 5x100, and we did do a 3-minute balloon inflation. So following the 3 minutes balloon inflation, residual stenosis was close to 0. So this is our post-procedure PCI. So we can see the good flow, going through the SFA now. And we did obtain hemostasis with our TR band. So 2 months later, the patients followed up with us in the clinic, and this was like the Doppler waveform we did obtain at that clinic visit. So we can see the nice PVR waveforms, and also the Doppler waveforms of the left lower extremity. So I didn't directly perform the intervention, but I guess key learning point for me to talk about today was that alternative access sites can be used judiciously as first-line approaches for infrainguinal disease, and also for pedal access in PAD. We need more additional studies to look at the long-term patency rates, but current literature actually supports technical success, amputation-free survival, and low access size complication. And some advantages I found out about this transpedal access is the fact that we have the increased pushability of the catheter through the occlusion, and we also have the less likelihood of entering into a side branch. These are my references. Thank you.
This paper is open. Any questions from the panel?
Yeah, very nice result. It's a little unclear to me why you needed the twin pass. Can you explain that a little more?
So I'm not really sure about it, but what my attendant did explain to me was that she just needed to place the antegrade lead just like the way she would do from the traditional fashion. So she just placed the twin pass from the right femoral sheath and placed the antegrade lead through the twin pass microcatheter.
So I'm going to just ask a question about what did you do for this patient prior to intervention? This is a claudicant, right?
Yes.
Has he been on basic treatment with cilostazol? Have he gone through some exercise training? This is a class 1 indication right now in the new PAD, guidelines. Before, when you have a claudicant, you really have to make sure you exhausted everything prior to an intervention. And my second question, is you have this common femoral involvement, and the question is, was endarterectomy considered, in this situation, and then see what the patient would do down the road?
Okay, thank you. So actually, the patient was on DAPT, he was on GDMT, he was on aspirin, Plavix, he was on food high-intensity atorvastatin as well. He also had a history of hypertension. Mostly his blood pressures were pretty much well controlled below 130. He was on losartan. So I guess the main problem was we also enrolled him into a supervised exercise treatment program. And then he had an episode of GI bleed, so he had to come off like the Plavix for some time. And during this time, that was when he presented with the exercise, limiting claudication. So that was the main reason why we decided to intervene. And for the second question, I'm not really sure if an end atherectomy would have been better than, deploying like the stent, the surgical options versus what we did.
Yeah, for common femoral involvement, the standard still is endarterectomy, and really we should not miss that point. Again, there is many factors have to be taken into consideration, and individualized discussion, with the patient is important. But that's something always to be considered.
All right, thank you.
And I didn't see the runoff, but was 3-vessel runoff?
Yes, I think at the end of the day, we did a CT with the 3-vessel runoff.
Where did the occlusion end? I thought it looked like it was in the P2 or P3 segment. Was it at the joint space, or was it a little higher than that? I can't remember.
So it didn't go all the way to the popliteal. I think it ended just a little bit.
So
like it came back
the
in the
question I have then is
canal.
for a claudicant, right? Because the profundo collateral is huge almost always. So a walking program almost always would be the right answer. I'm still not a big believer in pletal. We still recommend it, but if the EF's good, but many patients still don't do well with that. And so how do you think what is your surveillance going to be for the above thing? And then my more critical question is, I don't like putting sheaths in the tibials to begin with, but a lot of my colleagues still do. Was there any problems? I saw that you did the TR band to close it, but was there any issues afterwards?
So the patient actually had no issues afterwards. He actually followed up with us in the clinic at 2 months later. He was doing well, no issues with claudication again. And we recently saw him just last month for a 1-year follow-up, and he was actually doing fine.
It's amazing, isn't it?
Yeah.
All right, thank you. Very good.
All right, our next case is a deadly enemy lurking in the shadows. So that's exciting topic. Vasilis Polis, welcome.
Good morning. Hello. So my name is Vasilis Polis. I'm from Greece, and I will talk about a common disease within an uncommon disease. I have nothing to declare. So the patient is a 50-year-old male with a free medical history. 2 weeks ago, he suffered from shortness of breath and a slight chest pain, and he was treated at first with antibiotics for a possible lung infection. But the symptoms were getting worse. He came to the ER with tachycardia, low oxygen saturation, and a slightly elevated body temperature. We performed an echo first, where we found a dilated right ventricle and pulmonary hypertension. So all these findings were pointing towards a pulmonary embolism, which was diagnosed with a CT scan. In the next days, we tried to figure out why this happened. At first, we didn't find anything wrong. The abdomen ultrasound was normal. Cancer markers and immunological markers and thrombophilia genes were negative. And gastrointestinal endoscopy was normal. However, during a leg venous ultrasound, we found something that was not supposed to be there. And the CT angiography confirmed that there was a popliteal venous aneurysm which had thrombus inside without obstruction of the vein. So, up until that day, I did not know about the venous aneurysm, to be honest. It's an entity that was described first 1 century ago. And in 1968, it was the first case with a popliteal venous aneurysm. And 8 years later, the first case of recurrent pulmonary embolism from PVA. Up until 2015, around 200 cases have been described, including all ages, from 12 up until 82 years old. The diagnosis is confirmed when the vein diameter is over 20 millimeters, or 2 times the normal vein diameter. And most of these patients are asymptomatic. However, since the aneurysm is a thrombus generator, the 50% of the cases are discovered as during the investigation of a pulmonary embolism, although the risk of developing a pulmonary embolism through a venous aneurysm is relatively low. The other 50% is presenting with deep vein thrombosis, thrombophlebitis, or a popliteal mass. What about the treatment? When the patient is without symptoms and the aneurysm is relatively small, the best option is thought to be to observe the patient. However, the gold standard therapy is the surgery. The surgery is done when the patient is have symptoms or he has a big aneurysm over 20 millimeters, or the flow inside the aneurysm is turbulent, or there is a big thrombus inside the aneurysm, or there are thromboembolic complications. And what about the alternative? The alternative is anticoagulation, both after surgery or as a standalone therapy. However, most of these cases that have been treated with anticoagulation have a very high incidence of symptoms recurrence. And there's also the vena cava filter that is used as a bridging therapy towards surgery. So what did we do to our patient? First, we had to deal with the pulmonary embolism, and that's what we did. And during the next months, we had discussions with 3 surgery centers. And they all thought that the anticoagulation was the best option. We had a patient who has no other risk factors for pulmonary embolism. He was a young patient, and after 8 months of rivaroxaban, he has no thrombus inside the aneurysm. And the aneurysm was also quite small. So we prescribed low-dose rivaroxaban as a risk reduction for the recurrence of pulmonary embolism. And after about 3 years later, the patient was free of symptoms, and he had no thrombus inside the aneurysm as before. So everything seems to be fine. So what did we learn from this case? Popliteal venous aneurysm is rare, but it's a major risk for recurrent pulmonary embolism, which could be fatal for the patient. The bad thing is that there is no consensus on the management of these patients or even the diagnostic criteria of the popliteal vein aneurysm. However, the sure thing is that the treatment should be based on symptoms, size and shape of the aneurysm, the blood flow inside the aneurysm and possible thrombus presence, and the other risk factors for pulmonary embolism. Generally, surgical treatment is preferred. However, we have no data about the long-term follow-up. And the main question that remains is the role of modern oral anticoagulation. There are no analyses for the use of dogs, and not even for the long-term post-operative treatment of these patients. Thank you.
How big was the aneurysm in this patient?
It was around 19 millimeters.
So very close. So my question, if I was the patient, I would probably want surgery rather than take anticoagulation for, if you live 80 years, 30 years of his life. Was this not offered, or he refused, or?
No, he did not refuse. The surgery centers I would talk with, to be honest, they had no experience dealing with these situations. And since the patient was free of symptoms and he was doing well, there was no thrombus inside the aneurysm. So that's why we decided to go this way.
Yeah, the problem is you always worry as he gets older if there's any bleeding and they need to stop the anticoagulation.
Yes,
this is going to be a big issue.
That's the real issue here. But the surgeons didn't want to proceed with the surgery.
So do we know what the etiology of these aneurysms? I know there's only like 220 cases reported.
No, really.
Has anybody looked into the
something a mechanical complication of a trauma, but there's no real reason for this.
No history of trauma in this patient?
No, in this patient, no.
Okay.
No.
You know, the key is stenting's not the right answer here. So, you know, as an endovascularist, you can't just go down that road. And I guess from a surgical standpoint, do we have a surgeon on the panel? Is it just a patch or is it just a transposition? What do they do from a surgical standpoint?
I don't know exactly the procedure, to be honest, of the surgery. And it's
I'm a dumb plumber. Any other questions? All right. Thank you very much.
Thank you.
Outstanding
Thank you.
case. Next up we have is Prakash Upreti, addressing pseudoaneurysm of the ascending aorta with ongoing pericardial tamponade and pericardiocentesis and endovascular aortic repair.
Good morning, everyone. I'm glad to be here. Thank you, all the panelists. My name is Prakash. I work as a hospitalist in Rochester General Hospital, and I have 2 weeks off between my work, and that's when I work with cardiology department in advanced imaging, EP clinic, and hypertrophic cardiomyopathy clinic. And in that process, this case came across me. So if I miss some technical details, please excuse me. I apologize for that. I'm a little nervous as well, but let's start. I don't have any disclosure. So the patient that we are about to discuss is a 85-year-old male who presented to the emergency department with acute onset of chest pain and abdominal discomfort. He has pertinent medical history of new onset AFib that was diagnosed about 2 months ago on Eliquis, CAD, status post PCI, remote history of stroke, Parkinson's disease, and abdominal aortic aneurysm status post repair a few years back. So his initial vitals in the ED was blood pressure was slightly elevated. Patient was tachycardic but saturating well on room air. He appeared a little bit ill and in some distress. His JVD was prominent, tachycardic, irregular rhythm with the distant heart sounds. So in the process of getting labs and imagings, his blood pressure dropped after some time to 94/59 millimeter of mercury. So initial workup was significant for elevated creatinine and lactate of 6.6. His INR was also elevated to 4.8. High sensitivity troponins were negative. BNP was slightly elevated to 300. Initial EKG showed AFib with RBR. So not the best picture, but yeah, that's AFib with RBR. Because he was having chest pain, he had a CT angiogram of the chest done, which reported focal outpouching of the ascending thoracic aorta, which was 5.1 centimeter, with large hemopericardium. The report also said, like, hey, consult surgery, CT surgery urgently. This was the imaging that was described before that showed it reported as saccular aneurysm versus and with some tear in the ascending aorta, but because of the large hemopericardium, the thought was it is likely pseudoaneurysm with pericardial effusion. Echo was obtained immediately, which showed large pericardial effusion with RV collapse, and this is actually the echo clip with showing RV collapse. So basically, the patient was in cardiogenic shock. Blood pressure dropped, lactate was 6.6, distant heart sounds, massive pericardial effusion. So the issue was that patient was of 85-year-old with multiple, history of comorbidities. The heart team comprised of CT surgery and the cardiology team. They decided for conservative approach, offering no intervention because he's not a candidate for median sternotomy and open repair. Family also, the risks were explained, and the family declined the sternotomy and open repair. So the options were either comfort care, we do nothing. even if we drained the pericardial effusion, the pericardial sac would likely get filled up again because the etiology of where the pseudoaneurysm is there with this leaking into the pericardial sac, that will still be there. So, but we either just choose comfort care or we do something. So the something was planned. So something was basically what we. So vascular surgery was called into the picture. Initially, because his INR was 4.8, case center was given for INR reversal. He was taken to the OR. Urgent pericardiocentesis was done. There was about 500 to 600 ml of blood that was drained, and then it was auto-transfused via internal jugular vein. And immediately, the vascular surgery gained access through bilateral femoral arteries and placed 2 thoracic aortic endografts. Those both were of the same size, Gore 45 millimeter by 45 millimeter by 10 centimeter. One was placed at the level of innominate artery, and the other was placed just distal to the coronary arteries. So patient tolerated the procedure well. Echo was done post-procedure, which did not show any pericardial effusion, and patient was discharged on antihypertensive medications with close follow-up. And basic learning point for operator and the team was again, as much as literature review I did, and the CT surgeon and the vascular surgeon who were in this case, who guided me about this case, based on their experience and what they said was any ascending thoracic pseudoaneurysm, which is where patient is unstable, the standard of care is open thoracotomy and repair. The vascular surgeon said to me that he has performed some endovascular graft deployment in the ascending thoracic aorta, but those were the stable patients who had aneurysm in the past, but later had pseudoaneurysms, and this is all off-label. For descending thoracic aorta, yes, we do have endograft placement, but for ascending, in acute case, this was his first experience. So can we avoid the open repair, especially in patients who have comorbidities? So maybe that needs to be investigated more. Yeah, that's pretty much I have here. Thank you so much.
It's open for discussion. Any questions?
Very nice case. So classically, when we see aortic pathology with a concomitant pericardial effusion, you worry about extension of a dissection or something into the pericardial space, involvement of the coronaries. But from your CT imaging, it almost looked like there was a saccular pseudoaneurysm in the ascending aorta, and then a concomitant pericardial effusion. So were these two separate issues, or were they connected?
Based on what I was told, again, I might not have got all the images. I was told that it was the same, it was contained as pericardial effusion.
It almost looked like a intramural hematoma, right? So like a penetrating ulcer. Yep. And it basically is acting like an ascending dissection, a type A dissection. So I'm intrigued with the approach, because the ascendings are still surgical despite the comorbidities, but this is a nice temporizing way of closing it off without having to do a sternotomy. So I did have one question, though, and you may not know the answer, but once the pericardium gets filled and the fibrin starts acting, it's very hard to auto-transfuse that. I mean, that's just set up for DIC. Why do it that way? Just give them new blood.
That, I really don't have answer for that, honestly.
But that's a good point, because this came up on some other cases yesterday, and most people, panelists and people in the said the same thing. They prefer to give just blood and not auto-transfuse, because they've discussed some cases where they had right atrial appendage, right atrial thrombus, or other thrombi in other places just from the auto-transfusion.
It's interesting that they use a 4.5 by 4.5 core in an aneurysm that is 5.1, and it still sealed it.
Yeah,
And that's an undersized.
I don't know the neck and
The
the.
native.
Yeah, so I'm not very familiar with this, so maybe someone can
My guess
clarify
is
that.
is the biggest. That's what I was told. That was the biggest one they had.
It's
Yeah,
the
that
biggest, but I
sealed it
think
okay.
the
It's-
5.1 probably measured all the way to the outside of the aneurysm, so the true lumen of the
The
quote
true
unquote
lumen.
normal aorta was, yeah.
And it's been 6 months. This case happened. Patient is still doing fine in that regard. So I guess they did a pretty good job. Lactate came down. Yes, lactate was checked the subsequent day, and it came down. Yes.
I mean, it's a great save and a great demonstration. He was an hour away from death. So,
I believe so.
I think another note too, and my surgeons have made this point to me, when we have some of these potential either iatrogenic effusions or you're worried about hemodynamic collapse with draining that effusion, the surgeons aren't as worried as us endovascular people, but they always make the point, well, you can just stop draining it. You can just put a plug on it, which is right. If we have a pigtail catheter in there, you don't have to pull all the fluid off. You can pull off a small amount initially, see if you have an improvement or see if it deteriorates before you decide if you're going to drain the entire effusion.
That's a good approach, I think. Good thought.
It's a great example of when you get hemopericardiums, the challenge is fibrosis creates stranding, and then you get septations, which means you get loculated effusions. And again, bad luck, bad genes are just pure bad luck. If you get the septation sitting above your RV, then you tamponade the RV, and that's where your preload goes to nothing. And so the hemopericardiums, anything that gives you septation it's like when you perforate a coronary. Exactly. It's never good. Thank you.
Thank you so much. Have a good day.
All right, we're going to move on to the next case, case of coronary subclavian steal syndrome in cabbage patient, Asal Al-Bayati.
Good afternoon, everyone. Thank you for having me. My name is Asil. I'm one of the cardiology fellows at UCSF in Fresno. I'm here to present the case and to go next. Perfect. I have no disclosures for this case, and even for my attending who operated, no disclosures. The case today is a 57-year-old lady who presented to us with non-STEMI chest pain. She came with an extensive past medical history, including hypertension, active smoking, hyperlipidemia, and uncontrolled LDL of 147. Of note, she has a prior history of non-STEMI presentations that end up with 5 years prior. They end up with 4 vessels bypass. She had a lima to the LID, graft to the RPDA, and graft to the diag and OM. She was also found to have a carotid stenosis with a right ICA 70% and the left was 50%. About 9 months prior to this presentation, she also presented with a chest pain with non-STEMI, taken to the cath lab, and the decision was to intervene on her distal left main since she had an occlusion of the grafts to the diag and OM. So a stent was placed from the distal left main to the circ since she had a patent LID, patent lima to the LID. 2 months prior, she again presented with atypical, possibly cardiac chest pain. She didn't show any EKG changes or troponin. So she was, because of high risk, she was tried to evaluate her coronary interventions and perfusion. So taken for a nuclear stress test and showed that she has an anterior anterolateral wall perfusion defect. The plan was to see her as an outpatient because she has a lot of other comorbidities, including psychological problems, actually, with follow-up. She has a lot of social difficulties. She has a really strong history of leaving AMA from the hospital presentation, so we want to see if she established follow-up before doing any intervention. She did follow-up, and we did an echo that showed she has preserved EF with 55 to 60% and preserved wall motion, as we see here in the short axis, long 4 and 3 chamber view. This is the SPECT images, which was reported to be abnormal. And we see there is a large area of anterior wall and basal anterolateral wall perfusion defects, which were reversible, suggestive of LAD territory involvement. This is her angiogram that was done 2 months prior to her presentation. We see here there is a CTO of the native RCA, but she has a patent graft to the RPDA. She also has a patent distal left main to the circ during her current presentation. You see also some comparative flow to the LAD in this view. So we'll try to evaluate her lima, since the SPECT is showing that she has anterior perfusion defect. Just a disclaimer, in between this presentation and the one at the clinic, we were planning to do some intervention to her lima, since we saw during the angiogram she had a subclavian stenosis that we see here, with what we felt like a TIMI 2 flow, but not like as good as we expected when we relate that to the tight narrowing of the ostium of the subclavian. So in between, actually, I didn't put any images, but her aorta and the common iliac were very heavily diseased. So we also did some intervention on that in between. We did some peripheral intervention with ballooning to try to improve the access for the next intervention, because we thought there's going to be a difficult intervention for her lima. Unfortunately, she presented with chest pain, left AMA, and then end up with presenting again the next day because the pain was being persistent. And that presentation showed that she has a troponin elevation this time up to 3 without EKG changes, and pain was controlled. So now we're dealing with a patient with kind of questionable follow-up, but now she's presenting with active chest pain and non-STEMI in a left subclavian disease, which seems like to be important, supplying the anterior wall of the myocardium, which with recent SPECT showing that it was a reversible defect. Because of the heavy calcification that we saw in the subclavian, we anticipated that this patient might have not so easy intervention to the subclavian, and she need more like a lesion modification with IVL, lithotripsy. But we also anticipated that with intervention in lithotripsy in such an important vessel, that might end up having more dramatic consequences to the function of the heart, including that it would be completely dependent on collaterals, which with her prolonged PAD history, it might not be a really good, reliable source for hemodynamics. And also with IVL and heavy calcification in this patient, we expect that she might have a lot of emboli, atheroembolic events, which might compromise the flow. So the decision was to try to prepare with implanting an MCS device and anticipating that she might need it for the intervention. So a right femoral impella device was advanced through, we started with a pre-closure device with a perclosed, two perclosed devices deployed in the right femoral axis, and we upsized to 14 French, and we advanced the stiff wire to the LV where the impella was advanced, and we achieved good hemodynamic support. At this point, the patient was stable. So we did the angiogram of the left subclavian, and we can see here the tight stenosis, we estimated about 80 to 90%. She has still good flow, but also if you notice that the lima origin is very close to that stenosis and the vertebral artery, there is some overlap here, but based on the prior images, there is a very, very close origin and noxious stenosis. So with the impella support, we did a shockwave catheter. We advanced actually a pro water through the left subclavian, and then a shockwave catheter, a 7.0 by 60 millimeters were advanced, inflated to 3 to 4 atmospheres, inflated for 30 seconds, and 10 cycles were delivered. During that therapy, we noticed that her hemodynamics were completely supported by the impella, and her blood pressure dropped, and with the flat pressure line 90/80. So at this point, she's completely dependent on the impella. And this is after the intervention results. We see that there is an improvement of the flow. We feel like the flow is better up to like TIMI flow of 3. Repeat subclavian angio shows the stenosis also improvement from 90% to 20% with excellent flow. At this point, we didn't decide to deploy any stents, and we leave it at this point with a BTCI. So my key learnings for the operator and the team was that a critical subclavian stenosis can limit coronary flow in LEMA bypass patients and present with angina and even ACS patients. Although it's not very common, but there has been some reports with the ACS with a limited number of patients. Intervention in those patients, especially with bypass, can be a very high risk due to severe hemodynamic compromise from balloon inflations during interventions, poor collaterals, and possible atheroembolic events in those heavily calcified patients. LV assist devices can provide excellent support and facilitate advanced interventions, for example, for the lethal tripsy. All right. Thank you.
Quick question, why no stent? And I have a few comments to make, but why no stent?
So that was, it's a good question, actually. We thought about it, and because of the extensive history of the patient compliance, we were a little bit hesitant on the deployment of stents. The second reason was because of the proximity of that stenosis next to the origin of the LEMA and the vertebral artery, we didn't want to deploy any stents there. We want to compromise the flow.
So the risk of restenosis is very, very large here. And then, you know, usually if you take a contralateral view, you can see the takeoff and you can always avoid it. The LEMA was a little bit higher. The other thing I want to make a point of, and I may be wrong here, but I don't think this patient needed an impella in my opinion. And even if you did prolonged balloon inflation, you can look at every angiogram you have. There's always competitive flow in the vertebral artery. These people, I mean, that's what happens when you have subclavian stenosis. You have, if you shoot the carotid on the right side, you'll see or on the left side, you'll see the flow going to the vertebral down to the arm, and the LEMA still gets flow through the vertebral. So, I doubt you needed an impella, even if you did a little bit prolonged inflation in the subclavian artery.
Those are good points, actually, and I wish I had that picture. But once we started the deployment of the balloon shockwave, she completely flatlined and was dependent on it. So our interpretation was it's most likely those. Yes, she has some collateral flow, but it's not enough for that stress, and probably microvascular. Yeah.
Was that her only bypass?
I'm sorry?
Was that her only viable bypass?
Well, no, she had an SVG to the RCA that was open, a huge RCA, and the left system is...
So I agree with you. I think that,
the AF is normal.
Yeah, the collaterals from the vert, the thyrocervical trunk, even your external carotid to the thyrocervical trunk is usually enough to perfuse. And the risk of embolization, as you said initially, I'm sorry, I had a bathroom break, but that whole issue, the best steel for your coronary IMA is your subclavian. It'll always suck any embolization. It won't go down because it's diastolic flow. Just a technical question. This might be really a good use of axillary impella, because then you can do the impella and actually do your intervention in the same location in a retrograde approach. It's actually a fairly sophisticated, sexy way to do it, which may not be a bad way. So with PAD, to not have to go from the groin, it might be an alternative way to do it.
It's a great point.
If you go axillary, how are you going to push that through the stenosis and also then deploy a stent?
Yeah, I think that if you could, from what I saw, it was open, but if it was an occluded artery, then I think you're right. I think that becomes a bigger problem. But if it was a stenosis, then you just pre-dilate, get your way through there, and then go down the road with the impella. Because it'll take up oh, I see what you're saying.
You're still going to trap an impella behind the stent.
No, you're exactly right.
In this case, he didn't stent, but I agree with Mazen that I think the late loss, lumen loss here is high. The risk for that is high.
I was thinking of a coronary intervention rather than subclavian. I apologize.
That's an excellent point. There's so many ways to do this. Yeah, I agree with you. And, even I don't know why the flow got to zero with the impella. I mean, I don't know if the guide was just the balloon was so long, it's gotten the ostium of the guide and there were no pressures in the guide. Or if you covered the vert and yeah, but we'll see.
4 centimeters into the subclavian, right? And that's probably pushing into your vert. And
so if you covered the vert with it, that would be a problem.
The best emitter is the middle emitter. Right. And so for that to crack anything had to be more distal. I think
Yeah.
the benefit now having the
L6 devices. Having an L6 device now that's only a 30-millimeter balloon is beneficial. I'm not sure when this case was done. I know those are newer, but
A couple of months ago.
And I don't know, just to finish up, when you showed that 60 millimeters balloon being inflated to 4 atmospheres, you could see that the lesion gave way completely. I am from the school of thought that you don't use an IVL unless you fail a balloon or in the coronary a non-compliant balloon. If these don't open, then you can use an IVL, because if the lesion opened completely at 4 atmospheres, I doubt IVL was needed.
No, this is a shockwave balloon.
Yeah.
right, intravascular lithotripsy. I think the other point to make too, you showed that carotid ultrasound that was done. I presume that was around the time of surgery, but it's important to remember physical exam findings of subclavian stenosis. Every patient that comes in that I see in clinic gets a bilateral upper extremity blood pressure. Is a difference of 15 millimeters of mercury is diagnostic for PAD. So it's little things like that, looking for reversal of vertebral flow on a carotid ultrasound can also give you hints to these things too.
Good point.
Yeah, thank you very much. And
Absolutely.
I'll
Thank
just
you.
add to the non-invasive part of it, is you have to look at the images. Because I've had normal studies when you had clear reversal of flow in the vert, and it's just, they just don't pay attention. Some, they're reading 100 studies, and it sometimes can be overlooked. Thank you, that was a great case. Next up, Gajahana, again. Why do I always get your name wrong? I'm so sorry. I'm Spanish, so I make the J into a soft H. It's a problem. Innovate drug-eluting balloon angioplasty for surgical deep vein anastomosis of a right internal jugular vein to right atrium.
Good morning. My name is Deepak Raj Gajanana. I'm one of the interventional cardiologists at Cleveland Clinic, Akron. No disclosures. So this is the story of a 63-year-old female who had persistent facial and neck swelling and disabling orthopnea. So she does have a history of SVC syndrome. She did have a port in the right IJ for a long time for infusion and subsequently developed SVC syndrome. So she ended up having a right IJ to right atrial bypass using the deep femoral vein conduit on 16th of Feb 2021 at outside facility. Also has chronic AFib, hypertension, and hyperlipidemia. So as a part of workup, she had ultrasound of head and neck. One of the things that you look for is if there's like any mass effect pressing on the SVC. There was no mass or any fluid collection. However, the ultrasound of upper extremities, venous, when compared to the prior study in 2021, which was done after the surgery, it showed a post-thrombotic change with retrograde flow in bilateral subclavian and axillary vein. And as a part of further workup, she ended up having a CT angio of head and neck that shows a severe narrowing or diminution of right IJ to right atrial venous bypass graft. So the challenge is this is a 63-year-old has flare-up of Wegener granulomatosis. She's on immunosuppressive therapy. She has had SVC syndrome in the past. Within the 3-year, not even 3-year, within the 2-year, 6 months window, she presents with recurrent SVC syndrome. And it's very well demonstrated on the ultrasound and with the CT. So the challenge was how do we proceed forward? So these are just the steps that I highlight, and then we'll talk about the procedure subsequently. So our goal was to approach this via the right IJ and right femoral, and see if we can cross the lesion, and then just do balloon angioplasty and see how it goes. So we using ultrasound and imaging, that is a fluoroscopy, we had 5 French sheath placed in the right IJ and right common femoral vein. The right IJ sheath was upsized to a 8 French, and then using the right IJ access site, so we injected the contrast. As you see, it's filling the conduit, but then it ends up blind, and then there are some collaterals that go beyond. This is in a different view. So it doesn't get into the right atrium, it goes into the collaterals. So what we did was we were able to cross the lesion with the V18 wire, and then we exchanged this over a 035 by 90 centimeter navicross, and we used 035 supracore wire that we were able to place in the IVC. And then at that point, we were able to advance the IVUS. So what IVUS demonstrated was, as you see, there is some fibrotic stenosis, and there is no evidence of any thrombus. It's all fibrotic lesion in that conduit. So at this point, we decided we'll try with the gentle balloon dilatation and see how it goes. So the proximal part, we dilated it with the 80 by 60 Mustang, and then at the point of anastomosis, we went with the 70 by 40 millimeter conquest balloon. And then finally, we decided to treat it with the 80 by 80 millimeter impact drug-coated balloon. So this is the final angiogram. As you see, in this angiogram, you don't see any collaterals fill. Even if there are, it's very faint. But then you predominantly see the contrast getting into the right atrium. And this is the still image on the right side. So the key learning from this case was SPC syndrome in the past was attributed to the malignancy, mostly compression on the SPC causing the SPC syndrome. But then nowadays we use so many devices. There is use of pacemaker, ICD, and there are so many indwelling catheters that cause SPC syndrome, and that definitely overtakes the malignancy as the predominant cause of SPC syndrome. Now, when you see such patients with SPC syndrome, you always have to think about endovascular feasibility of treatment. So is this patient somebody who can be treated endovascularly before offering surgical therapy, before offering the so-called definitive therapy, which is surgical revascularization, wherein you bypass it. And you should reserve it for, and you should reserve the surgical revascularization for recurrent SPC syndrome cases where your endovascular therapy fails. Now, in our case, we had already missed the bus. In other words, the patient was already treated with the surgical approach at the outside facility, and all we could offer her was endovascular therapy with balloon dilatation followed by DCB, and probably further advances in dedicated balloon or stenting for venous cases would help us better treat these patients. With this, I conclude, and I'm open for any suggestions.
Well, this is really a great case. Question is, how did you get the wire? I mean, you barely could see. Actually, you don't even see the lumen when it comes to the right atrium. How did you find that?
So I think we got lucky. I think we got lucky with the V18 wire a little bit, maybe, well, of course, we used it over a microcatheter, and we were able to pass it, and we were able to get into the IVC. I mean, that's what I was saying. We were lucky.
Better be lucky than good. That's
Yeah, so
absolutely. Lucky is good. You know, the other thing is it's so fibrotic. You know, have you considered? I mean, it's all kind of off-label use. Have you considered the use of some laser treatment to the fibrotic area so you can get better expansion, you know, of this graft, you know, with after the DCB?
Well, something to think about. The other problem with this patient, as I mentioned, this is a lady who has rheumatologic disease. She is already on immunosuppressive therapy. Sometimes you worry about rupturing this, and then ended up opening her up on the table. So I think we decided to go with the safe approach, try just DCB, relieve her symptoms. Our goal was not to give her a definitive treatment. Our goal was to just improve her symptoms, which was swelling in her face.
I mean, but in a way, you need a definitive treatment. She's young, and so here's my question. Yes. These are tough. I've done a lot of these are very tough, especially in malignancies, because you don't know what you're dealing with. And I've had to actually wire from the right atrium up at times because we could not come from downstream. And it's always a good idea to get a pigtail or catheter in the right atrium when you're doing this from the femoral approach and try to get it from above. They're hard. The only two things I want to, do you know how big that conduit was? Because an 8.0 for an SVC is very small. Mm-hmm. And I worry about long-term patency. And the other thing, these people do better with stents. We usually use wall stents or everything, even if the stent goes a little bit into the right atrial junction. Yep. And even if the stent does not open all the way, I've had patients that they come back, you know, you start with like 10 balloon and the stent is probably 14 or 16. You need to make sure elongation is okay. Yeah. You bring them back in a few months and you dilate them higher because, you know, there's so much fiber. Then you bring them back maybe in a year and even dilate them to 12 or 14. Yeah. I'm a little bit concerned about the 8 size, how much long-term patency that would be.
So as I mentioned, so in this patient, so this was just one attempt to see if the symptom improves, as you mentioned. So when we stent, there is so much disproportionality. You worry about the stent migration into the RA. So I think if probably future, when she comes back next time, probably we may consider doing stenting. And then, as you mentioned, bring her back again to better dilate it, especially at the junction where the stent ends at the right atrium.
Yeah, as long as it's anchored and it has a lot of anchoring, then it won't migrate. It can't. They say you shouldn't. But I guess my question, I don't mean to interrupt you, but my question was a little more simplistic. How did you measure success? I mean, the way I've always done it when I do these is I look at the RA pressure. That gives me what it needs, and see what the pressure difference was. Did you get any of that?
I don't think we measured it. So
that'd be a really good way to know if the 8 is enough, right? If it unloads to 12 and the RA pressure was 8, then I'd say you're in the fighting range of being successful.
To be honest with you, what we aim for is a delta pressure of 2 to 3 millimeters of mercury in the venous system, in the SVC, because 5 and above is too high.
Okay.
So if you measure the pressure in the sheath and you have the pressure from the femoral, and there's more than 5 millimeters of mercury, it's hard to say you've achieved your goal.
Yeah, I agree. That is true.
All right. I think that's a great case, though. Okay. All right. We have to move on.
Thank you.
Thank you. And I will get your name right at some point. We have a player to be named later, Alex Warner. Are you here? Outstanding. Yes. I love this title. Lucas to the rescue. I don't know who Lucas is, but you're going to tell me. Maintaining flow for the ECMO support in myocarditis.
Perfect. Thank you, everyone. Presenting on behalf of Dr. Singh today. Unfortunately, he couldn't be here. My name is Alexander Warner. I'm a first-year cardiology fellow at Medical College of Georgia. We'll present Lucas to the rescue, maintaining flow for ECMO circuit and support in myocarditis. I have no disclosures. So our case presentation is a 43-year-old male, no significant past medical history, presented for 6 days of chest pain and dyspnea, pertinent social history, Holly substance abuse, methamphetamine, cocaine, tobacco use, and alcohol use. Vitals on admission, he was tachycardic to 149, blood pressure was 104/89, respiratory rate was 36, and he was satting 100% on 2 liters nasal cannula. Here's his EKG, and it was atrial flutter with a 2-to-1 block. So more labs were obtained in the ED. His BNP was 671, high sensitivity troponin was 29, and his lactic acid was 3.9. So here's kind of where the case took a turn. So initially started on amiodarone for the flutter, became hypotensive, and then was put on pressors with norepinephrine. In the ED, he was focused with his left ventricular ejection fraction less than 15%, which kind of pivoted the case, so dobutamine was added. At this time, he continued to become more hypotensive and tachypnic. We tried a trial of BiPAP. Unfortunately, he remained acidotic on 100% FiO2, and his lactic acid was worsening to 11.2. So the decision was made to go ahead and intubate the patient. After that, he went into cardiac arrest with PEA. 4 minutes, he had 1 dose of epinephrine, and ROSC was achieved. But at this point, he was on dobutamine 2.5, epinephrine 0.5, and norepinephrine 0.2. So young gentleman, no past medical history, EF is 15%, and he arrested in the ED. And so step 1 for us is we did ECMO cannulation for him in the ED. So our cardiac anesthesia and CT surgery came down. Here's a TE image that shows the venous catheter for the ECMO cannulation. So where our case became more complicated is that ECMO was going 4 to 4.5 liters of flow, and this was our TE image. So you can see kind of the smoke here. We don't really have any forward flow, so the concern at this point was that we would clot off potentially the cardiopulmonary circulation, and what do we do from here? So this was our clinical challenge. So how we kind of addressed that is we actually used the Lucas device, which is an extracorporeal compression device to compress the heart to try to make sure that no clot formed. And so at that point, the cath lab was activated. This gave us a little bit of time to decide how we could escalate our mechanical circulatory support, and the patient was ultimately taken to the cath lab. Sorry, wrong button. Step 3, so in the cath lab, we put an Impella CP in place. You can kind of see that right here. And we have a TE probe that's down there that's guiding this as well. During the procedure, actually, we had high ECMO flow rates. So what happened was the ECMO cannula had migrated into the intraatrial septum. So under TE guidance, we were able to pull that back. And after that, we put a right IJ catheter to do a right heart cath. So here, we'll click 2 of these so they can go. So this shows our Impella catheter coming through the aortic valve. We were able to cross easily, and we were able to do this in the cath lab. So afterwards, both with ECMO and Impella support, we did a right heart cath. The right atrial pressure was 7, RV was 20/7, PA 20/10, our pulmonary capillary wedge pressure was 7, and our PAPI was 1.42. So the resolution of our challenge really took a team effort. Cardiac anesthesia and CT surgery, who cannulate at our hospital, helped immediately in the ED to stabilize our patient. Interventional cardiology assisted with Impella placement. Advanced heart failure helped as well once we got to the CVI ICU and our ECMO specialist, so it really took a team effort.
Could you just stay on that photo for a second? I'm going to interrupt you for a second. The happiest person in there is anesthesia, who always uses gas. Everybody else seems too serious. I just wanted, why is that the case here?
Oh, that's a good question. I don't have an answer to that. I've seen Dr. Bailey be pretty intense, and she's great, so I think it was a good picture.
Everybody else is just intense, and she's just super happy. So, I'm sorry, continue.
No worries. So remainder of hospital course. So for his myocarditis, he was treated with methylprednisolone. Day 5, he was decannulated from ECMO. Day 6, Impella was removed. On day 7, he was off pressors and off inotropes at day 12. And 1 year out from that, he was seen in heart failure clinic. At time of discharge, his EF was 30%, and then most recently it was 41%. He's on GMT, all 4 pillars, Entresto, carvedilol, spironolactone, and Farxiga. So summary of the resolution to our challenge is initial ECMO cannulation after PEA arrest. The TA was critical in this point. We saw smoke. We didn't see forward flow. Knew we had to inact. We couldn't leave this patient, and if they had a clot into the cardiopulmonary circuit, would have severely limited our options. So we used the Lucas device, or an extracorporeal compression device, to maintain flow while we had time to make a decision. Activated the cath lab quickly, upgraded to Impella with ECMO. Sometimes you'll see Impella or ECMella, depending on where you're from. So just a couple things. I think TE was pivotal in this case, helped guide our initial ECMO cannulation in the ED, confirmed that we still had more work to do with the cardiac standstill and the smoke that was present, and we needed to further escalate our mechanical support. Ensured proper position of the Lucas device. This allowed us to mobilize the cath lab team and get the Impella in quickly, so we had more hands available in the cath lab, and it allowed us to adjust the ECMO cannulation after Impella placement. So there's been more evidence in this concept of ECMella or ECPella using left ventricular unloading. In this case, that was our Impella to improve outcomes in cardiogenic shock. Here was a review of articles. Here trended towards left ventricular unloading, aiding the patients. So kind of that combination approach here was key, I think. So key learnings for us, it was critical to maintain proper flow throughout the whole entire circuit, not just the ECMO circuit, but also the cardiopulmonary circuit as well. The extracardiac compression device was critical to maintain flow, give us a little time to update and decide what we were going to do with our mechanical circulatory support. ECPella or ECMella was an option for this patient who had myocarditis and had full recovery. Here are the references, and thank you for the opportunity to present.
You know, this is a great case and a great save, to be honest. The use of TE, you emphasize that quite a bit, and I think that's really important, especially with the Lucas, you know, and if you position that Lucas just a little bit high up into the sternum, I think it would have defeated the whole purpose, you know, and you would have got actually really not much of a flow or improvement. So I think it's really critical that what you have emphasized at the TE is really critical in that case.
I have a quick general question. To when you have that much smoke, is the Impella safe? Do we? I mean, I don't know the answer. I'm just asking.
That's a good question. So I think on that point we had to act pretty quickly. Still, patient was full code.
I think this is a great use of Impella. Don't misunderstand me, but I'm wondering whether the risk of stroke is higher with like that much smoke.
That's a good question. I'm not entirely sure. So we were able to get him heparinized pretty quickly. Initially, it was 10,000 units of heparin, wasn't anticoagulated to 180 to 220, pushed another 30,000 units, and we got him anticoagulated. Our concern was that if he formed a thrombus, that would be increased risk for stroke as well, and then it would have taken away any kind of impella support, either CP or cardiopulmonary. So there probably is a risk with that, but we were kind of in a critical situation.
And I missed that. Was his initial diagnosis viral myocarditis, or what was it?
Yeah, so good question. So we didn't have his COVID and flu were negative. We didn't have a viral panel initially. His UDS was negative, so it's presumed myocarditis.
So a couple questions, or a couple thoughts. One is that smoke that you see is a great example, at least visually, of the retrograde pulse that you get with ECMO. Everybody believes it's a great idea, but it really does put afterload on a failing LV. And so the Impella is the only one that really advances normal contraction, and that's a wonderful use of it. And then you said 220 for your ACT. What do you guys use for your anticoagulation? How do you follow these?
During the case or?
Post. I mean, I'm presuming it stayed in for a few days because you described it did. So.
Yes, sir. So we maintain on heparin, drip, and then monitored with ACTs.
What's your goal ACT, I guess the question was?
Yeah, so because we live this, and we found that ACTs are awful following these things. We went to factor 10A.
That's what we do.
And so, 0.2 to 0.3, and so that, you may find a lag in that ACT, and so you may have thrombus or over-anticoagulation, which was what we found during COVID. We basically, it was a clean kill on a lot of folks who just bled out. And so the factor 10A level is really the way to go with these. And so you may just want to have your thrombotic committee. As a first-year fellow, you can really champion this, but the idea is to really try to figure out what's the best anticoagulation, because ATTs lag to what you truly anticoagulate.
Yeah, we don't use ACTs on the floors.
Kind of asking a heart failure question. So in the blood gas you showed in the beginning, there was severe evidence of hypercarbic respiratory failure. Do you think it's possible that the low LV function and PA arrest was simply from acidosis?
Definitely possible, and they were using bicarb pushes at that point to try to address the metabolic acidosis, but definitely possible.
The stair step was amio, right? And then it went to butamine, or neo, then it went to butamine. So you had a combination of things that probably killed the LV, right? That's it.
Well, I mean, this case illustrates the importance of a team approach in complex cases, and I really think we should be emphasizing that in all these complex cases that we see all the time. You guys have done the right thing here. I mean, this is what it is. It's a big save, no question about it.
Thank you.
Thank you.
All right, we'll go to our last case, Save the Brain and the Heart, Laser Fenestration of Thoracic Endograft for Ruptured Thoracic Aneurysm by Anne Kelly-Rudy.
Thank you for having me up again. Again, I'm Ann Kelly-Rudy. I'm one of the second-year fellows at Baylor in Dallas. My case presentation is an 85-year-old male with a ruptured thoracic aneurysm. He presented to an outside hospital with the primary complaint of chest pain radiating to a back, and was found to have a ruptured thoracic aneurysm. The CT I'll show in a second. This thoracic aneurysm was known. It was last imaged the year prior, measuring with a maximum diameter of 5 centimeters. Other pertinent cardiovascular history, he did have a CABG remotely back in 1999 with a patent lima to LAD, as well as diabetes. This was his initial scan. Hopefully it plays well. He showed up to us hypotensive, which we maintained in the ICU, and we emergently took him to our hybrid suite. You can see that he has a left hemothorax concerning for rupture.
Consistent with.
Consistent with. I'll let the rest play. So the clinical challenge, this is obviously an 85-year-old male. He has a ruptured thoracic aneurysm. He is hypotensive, hemodynamically unstable, and he has a couple of pertinent surgical and medical history that we need to pay attention to. Most importantly, he had a sternotomy and a lima to LAD. His proximal seal zone sometimes can be difficult to assess during a rupture. It's hard to tell exactly where your rupture is. We presumed that it was probably in the lesser curve. There was an area of atherosclerotic plaque, and we felt like in order to gain adequate seal zone, we would have to encroach, if not cover, the left common carotid and left subclavian. So we discussed endovascular options, open options, which at this point are really not an option. So we took him to the hybrid suite. We did a TAVR repair with a laser fenestration and VBX stent placement in the left common carotid and the left subclavian. We did a left common carotid cut down and a left brachial artery cut down, and laser fenestrated from a retrograde approach. I think that first, yeah. So that's the first video. That's the left common carotid. We placed an 8x39 VBX stent and the left subclavian with an 8x59 VBX stent. You can see that lima. Fortunately, he had no neuro changes. We always have neuromonitoring and no EKG changes concerning for any issues with his lima. He did great, actually. So he was discharged, I think, around post-op day 14 from the hospital. We did place a chest tube in the operating room as well. This is his 6-month post-op CTA. He's 85 years old. He's going to an Alaskan cruise. So he's excited about that. So I'll show, oh.
He needs a personal physician on that.
Do you mind going back? Yeah, do you mind playing that for me? So this is his postoperative CTA, where you can see the patent VBX stents. The only thing that was a little bit concerning to us, and you'll see this, is the distal landing zone. There's a little bit of evidence of infolding. Another kind of principle that's important in ruptured thoracic aneurysms is to always consider oversizing your thoracic stent. So it's possible that we oversized that stent for him. So key learnings for us for this case was to obtain a proximal seal into healthy aorta, and sometimes that does mean needing to address your common carotid and left subclavian. You need to understand the importance of maintaining patency to the left carotid and subclavian for cerebrovascular, your vertebral artery, which is important for spinal cord ischemia, and then, of course, in this patient, lima flow for his bypass. Again, another thing that I love about vascular surgery is there's multiple techniques for debranching the thoracic aorta. You can combine open, you can combine endovascular. Another approach to this could have been an extrathoracic bypass, but we felt like this was going to be the fastest revascularization and approach to his ruptured aorta. The total case time was less than 2.5 hours.
Eurovascular surgery?
Yes.
Okay, awesome. So how long does it take to fenestrate this and put the stents? I mean, because he has a lima to the LAD.
Yes.
And obviously you're covering both vertebral and carotid on the left side. You don't know about the circle of Willis, if that's complete or not. So, how quickly can you guys do that?
Yeah, so in my experience, if the laser fenestration is going to work, it's going to work very quickly. But if we're having some issues, and that usually has to do with the angle at which either the left subclavian or the carotid comes onto the arch, then that can be difficult. What I didn't include is we did have a safety wire from his carotid into his ascending arch, so that if we did have to snorkel a stent, which obviously has other issues with endoleak and isn't a perfect repair, we could.
So you have cut down on the carotid, cut down on the subclavian, and what you do is you
cut down on the brachial.
Brachial, sorry.
Yes. Yeah.
And then what you do, you just do the laser from these approaches?
We did do retrograde laser fenestration. I haven't had experience doing antegrade, and actually in the aortic session right now, they're kind of going over arch debranching, and I think it's definitely a topic that is discussed a lot between CT and vascular.
Is it the Spectranetics or the Philips laser?
I believe.
208, or is it the Ariane laser at 322?
I believe it's, yes, thank you.
Just got the Ariane today.
Yeah.
Spectranetics, and so is it high fluence and high pulse rate? What do you use?
That's a great question. I was thinking before I needed to look a little bit more into the laser. Dr. Russell, maybe you can help me out.
I haven't been in when Vasquez and them have been doing that, but yes, I'm not sure exactly what
It's got to be, I mean, the vapor, and what size do you use? Is it a 2.2 laser or 2.6 laser? What do you guys use?
Again, I probably need to know more about
because
that.
Because the vapor bubble, it gives you 3 millimeter on a 2.6, right? Something like that. And then the high fluence gives you the larger bubble burst, and then the front tip is hot, and so that's what gets you the hole. I guess the key is that, and to your point, you don't know if you're vaporizing the PTFE, which is what you want to. But if you sit on the nitinol, you may sit there forever and not do a damn thing.
We chose a terumo graft for this, so it's actually a Dacron graft.
You know what I mean? It's
Yes,
just a
yes. There is. I'm just saying that there is a lot of debate whether or not you can do a laser fenestration into PTFE. I think people are doing it, but that is another kind of hot topic for the core grafts.
You hit a stent strut,
Correct.
or you hit the fabric. That's the key.
Yeah.
And then once you do that, is it always a VBX, or could you do a Viabond in there?
You can do a Viabond. We elected to use VBX, I think, just for a little bit more secure placement so that we knew where we were deploying. And
It will
that's
also
been my
anchor you, right?
Yeah.
Because it anchors the graft, so it doesn't move, which is really critical.
Not
Yeah.
knowing how you're interacting with some of the cage
Mm-hmm.
and the structure of the actual TAVR, I think is important.
Yeah, and I think with Dacron, we have seen that it does stretch a little bit more, whereas opposed to PTFE, it can be a little bit more kind of cinching. So we have been using VBX, but I do know people use Viabond.
And is there a risk, I'm just asking out of pocket, but is there a risk for not pseudoaneurysm, but type 1 endoleaks in essence based on the sides not being covered?
Yeah, I think there is. I'm actually trying to do a project comparing branch devices versus laser fenestration devices. We don't have a ton of, one, long-term follow-up, and two, I've noticed that a lot of our patients, especially our dissection patients, are not the best at following up. It's kind of like the trauma surgery population in my experience. So unfortunately, we just don't have those images.
And then I'll shut up after this question.
No,
So
this is great.
is there, how did you control him getting into the OR? Did you put a coda balloon up to stop the bleeding, or did you just let him bleed out while you were getting him set up?
We were pretty quick to get in, but we did allow permissive hypotensive. We do have kind of an emergency ruptured aneurysm set so that if we did need to, put a balloon up, we could. But he remained what we considered appropriately hemodynamically stable. We wanted to make sure he was talking, awake, but we did allow permissive hypotensive.
Post-CABG, right?
Correct.
Yeah,
Yes,
so
20. Yeah.
In that case, it might get a little riskier.
Yeah.
So as you're doing your laser fenestration, have you seen, you're reviewing that whole topic, are you seeing any perforations reported?
I haven't seen in our, but our numbers are small. I think we have about 10 or 11 laser fenestration for the arch, and we have a lot more branch devices. In those 10 people, we either didn't have suitable follow-up or their scans have looked good, but they're usually 6-month scans. So we just don't really have that information yet. So maybe an ongoing project.
On someone like this, did you guys consider doing the subclavian first, knowing that he had the lima for instability? Because I noticed you guys did the carotid first. Or was it just, let's get this done and move proximal to distal?
We elected to do the carotid first. There was discussion, I think, just from a vascular perspective, we wanted to make sure that we were protecting his cerebral perfusion. Obviously, we've got great anesthesia. I think at where we're at, cardiac anesthesia, they were very communicative.
I
with
think
us.
the heart can tolerate a little bit more ischemia compared to the brain.
Right.
But yeah.
Either way you look at it, it's about a 20-minute deep breath and hold. Right.
Yeah. It was.
Yeah, 20 minutes, they'll stroke out big time, but 20 minutes of ischemia, knowing that he has bypasses, hopefully the others are and we don't know if his LAD is 100% and the lima is going to, so I guess.
All right, well, that's a great case. Thank you very much. All right, so we are at the conclusion of this session. The panel has to stick around. We have to come up with a winner and a runner-up. And then I guess, is it tomorrow they then do is it like a
Tomorrow's the final, yeah.
All right, fantastic. Well, good luck to everybody. Thank you for your presentations. Really great cases. We really appreciate it. I want to thank the panel for their time and Dr. Shamas for sticking it out with me for this hour and a half. All right, so congratulations. Have a great lunch, guys. Have a great session on the remainder of the meeting.